So I'd like to thank everybody for coming to the fourth Vision seminar that has been given during this COVID lockdown. And today it's my great pleasure to welcome Dr. Barbara Brous. Dr. Brous is the head of the ophthalmology referral service in a multidisciplinary hospital in Germany. Before being there, she received her veterinary degree in 2005 from the University of Munich in Germany, and then underwent a residency training program at Willow's Referral Centre in the UK, and holds the European Diploma in Veterinary Ophthalmology from the ECVO. She has previously worked at the university in the Munich Veterinary School, and has recently joined the ophthalmology service previous to this in the University of Vienna. And now her clinic, her private clinic, is at, in a clinic near Frankfurt. So with no greater aplomb, we will continue with the webinar and welcome Dr. Brous.
Hello, and thank you very much for the nice introduction. It's actually a pleasure and an honor to be able to speak today and to talk about ERG. So we are going to talk about ERG today, and my first encounter with ERG was when I was actually a PhD student. So I was fresh and green to ophthalmology. I had no idea at all. And my boss came along and he said, like, look, we've got a new machine here. It's called an ERG, and it's to test vision in animals. And please, tomorrow, I want you to show me the machine and how it's working, so go. So I was, of course, quite challenged with that idea, and I had to learn a lot. I had to learn where to place the electrodes. I had to learn how to interpret the ERG. And finally, I also had to learn that it's actually not about testing vision in animals, it's just to test the retinal function. And ERG is for me, yeah, I like ERGs, I love ERGs, and I think I've got quite a practical approach to that. And this is what I'm going to show you today, like practical approach to ERG and like daily clinical changes and challenges for you to be more happy with your ERG. So we are going to make a plan now. I'm going to talk about the basics first. So you need to know some physiology, although it might be painful. So it's really important. Without physiology, you have no idea what's going on with your patients. Then we are going to talk about ERG protocols, about some recommendations, how to prepare your patient and things like that. And then finally, we are going to talk about some cases, some clinical cases, just to give you a practical insight to everything. So the basics. So once again, we cannot test vision with the ERG. So we can test the retinal function. And actually the ERG is quite working similarly to the electrocardiography. However, the heart is beating on its own, but the retina is only working if you stimulate the retina with light. The electrical signals, they are really, really small. So this is micro voltage you need to record. And that's the reason you need that ERG machine to give you stronger readings and that you actually can see the signal. What is actually happening in the retina? It's actually a miracle. I think it's really, really fascinating. So light is actually a wave, and what you are recording is electricity. So this miracle of transformation, this is occurring in your and my and animal's retina. That's really cool, actually. So the retina. Do you remember your days as a student? Well, look back at my time. So that is the histology slide of the retina. And when I was a student, I was really quite confused and thought like, oh my goodness, the 10 layers of the retina, or actually there are 9 because the retinal pigment epithelium is not part of it. Where is what and how shall I ever remember that? So we're going to make it a little bit simple now. Look at that slide. So this is the retinal pigment epithelium here, and here at the bottom is your vitreous. And the light is actually showing through all these layers until they reach the photoreceptors. And they are actually painted here in the blue and red colors. And then afterwards, your signal is going to be transferred to the bipolar cells. These are the yellow guys here. And then finally, they connect to the ganglion cells. And the ganglion cells, they transfer the signal out of the eye. So For now, just remember your photoreceptors, this is where your miracle occurs, so the transformation of light into electricity. Then the signal is going to be passed on to the bipolar cells, and then finally you've got your ganglion cells. So just keep these three types of cells in mind until you. So the photoreceptors. This is just a little bit of an easy drawing. What happens inside the photoreceptors. So it's quite, actually the eye is quite interesting. So at nighttime, if it's dark, this is your rhodopsin membrane, you actually have got an open sodium channel. So the sodium can flow into the cell, and then you've got a potential of -30 microvolts. However, if there is light shining into the eye, then your sodium channels, they will actually close, and then you get hyperpolarization of -70 microvolts. This is completely the contrary to every other nerve in your body. So normally, if a signal is passed on, you always get a depolarization. So remember your biology days in school, depolarization happens normally, but in the eye, in the retina, you get hyperpolarization if the photoreceptors are stimulated by light. So that is a massive difference. So remember, once again, darkness, you've got a resting potential of -30 microvolts. Your sodium channels are open. And in light, your sodium channels are closed and you get hyperpolarization. And that's quite important to understand when you're looking at your ERG. Because do you think photoreceptors are contributing to the ERG? Yes, of course, after all that talk from me, it must be, so they must contribute to the ERG. Yes, they do. So remember that hyperpolarization of the photoreceptor cells, you see them as a negative A wave in your typical ERG. So that's this little declination here at the bottom. And then next step, it would be quite nice to differentiate between rods and cones using your ERG. Why is that so important? Well, they are retinal diseases like progressive retinal atrophy, where your rods go first, normally go first, and then your cones will follow, depending on the type of PRA. So it would be quite nice to use the ERG to differentiate that quite early, and most importantly, before actually the clinical symptoms occur. So can you do that with the ERG? Yes, you can. So first of all, it's quite important that you can understand the difference between the rods and the cones. So we start with the cones. The cones are there for color detection, and they need to be activated by approximately 1,000 photons, so quite a lot of light. And they have got a high flicker fusion frequency. This seems to be quite complicated, but actually it's not. So what is the flicker fusion frequency? Remember these days when the first films, the first movies were made? These early films, they consisted out of approximately 50 pictures per second. And always a signal per second is called hertz. That is this HZ little abbreviation here. So when we were looking at a movie, we had a fluent picture, a movie actually when there were more than or around 50 pictures per second, or actually more. However, in most animals, this wouldn't be a movie. This would be one picture after the other. So because the flicker fusion frequency in dogs is much higher, so they are much more better able to detect a single picture, and it's even higher in birds. So a budgie has around 90 flicker fusion frequency and even 130 in falcons. So they are hunting, they are flying in high altitude, so that's really important why they have this high flicker fusion frequency. And this high flicker fusion frequency is something which occurs in the cones. You will see in a second that the rods have got a quite lower flicker fusion frequency. Right, so the rods. They can be activated by approximately 5 photons. So remember, 1,000 in cones and 5 in actually rods. So they are much, much better able to see at nighttime with low light intensity. They are not so good at detecting color, and they have got that low flicker fusion frequency of approximately 10 Hertz. So how can we use this knowledge? Is that any good? Yes, it is. So if we want to test our rods, then we need to use a really low flicker frequency, so 10 or below hertz. We can use a very low light intensity because then the cones will not be able to work under the low light conditions. And we can also dark adapt our patient and record the ERG signal every few minutes. And then we should have an increasing signal that should become stronger because our rods, they are dark adapting. When we want to check our cones, then we use a high flicker frequency to leave our rods behind. We can use colored light stimuli, and we can finally light adapt the patient so that the rods will bleach and will not interfere with our cone function. So now we have got some basic knowledge about the photoreceptors. What about the other cells in the retina? Please remember, we were talking about photoreceptors, these guys here, and then the signal was transduced into to the bipolar cells and finally the ganglion cells. What with these other guys? Right, so the bipolar cells, these are quite helpful little cells. So they are quite like these firemen here. So that is, they fight against the flooding and they pass on scent packs from one to the other. And they are like our bipolar cells. So they pass on the signal from the photoreceptors to the ganglion cells. So the cones are directly connected to the bipolar cells, and the rods are connected to the bipolar cells via horizontal cells. These bipolar cells are actually quite interesting. So if you look at the area centralis, then you have normally or often a connection with one cone to one bipolar cell directly to one ganglion cell. But in the periphery, you will have a quantification of the information, and you will have a lot of rods connecting to one bipolar cell and then off to a ganglion cell. So you've got a converging system in the periphery and one-to-one system in the area centralis, and that in the area centralis we have a much better resolution, one-to-one. And do these bipolar cells contribute to the ERG? Yes, they do. So this big, large B wave here is deriving from the bipolar cells. They form the B wave. And then finally, the ganglion cells. These are again quite interesting cells. So there are the third neuron. So first photoreceptors, second is bipolar cells, and then the ganglion cells. And they perform the signal transduction to the brain. So they are really, really long. They form actually the optic nerve. And these are really important cells. Of course, you have got the highest density of ganglion cells around the area centralis, as we discussed before. And this is just some numbers to give you an idea how many ganglion cells they are. They are closely located to the vitreous. So again, the light is coming here from the bottom. And so they are quite located close to that. And then they bring the signal towards the brain. What do you think? Do ganglion cells contribute to the ERG? No, they don't, at least not with your routine flash ERG. So you will not see the ganglion cell functions there. Right, so we have talked about the photoreceptor cells, we have talked about the bipolar cells, and we have talked about ganglion cells. So let's have a look. We've also got these amacrine cells, and we've got horizontal cells. So again, photoreceptor cells, bipolar cells, ganglion cells, and these guys in between, we need to discuss them as well. What do they do? Just in simple terms, they help to reduce optical chaos. So you can imagine if every photoreceptor is firing because of light and every bipolar would fire as well and every ganglion cell would fire, then your brain would be full of information and that wouldn't make sense at all. It's helpful that there are some cells to silence signals and to enhance other signals, and that is in simple terms the task of the amacrine and horizontal cells. Horizontal cells, these are these guys actually here. There are different classes of them. They help with light adaptation. They perform lateral connection to the photoreceptor cells. And of course, the most important question, do they contribute to the ERG? No, they don't. Next cells, these are the amacrine cells. They get their name from the fact that they don't have an axon. They are located here, close to the ganglion cells. And they also there to do some signal, influence the signal transmission, also to get the signal a little bit clearer and to reduce confusion. Do you think that they contribute to the ERG? Well, actually, probably yes. So there are some believe not, but they are most likely contributing or producing the so-called oscillatory potentials. So if you look, they occur between the A and the B wave, and on the ascending part of the B wave, you see these little guys here, these little wavelets, and these are the oscillatory potentials. It's sometimes hard to record them because you need special filter settings, so you might not always see them on the ERG, but when you get these little wavelets on your B waves, then remind yourself that these are normal oscillatory potentials, most likely coming from your amacrine cells. So who else is here? We've got the Müller cells. These are the second most common retinal cells. They are within the entire retina. Earlier on, people believed they were part of the B wave, but actually they are not. So they do not contribute to the normal flash ERG. And then finally, we've got the retinal pigment epithelium. This is not a true part of the neuronal retina. The RPE is helping to nourish the photoreceptor cells. They remove also the waste from the photoreceptor cells. And big question, do they contribute to the normal ERG? No, they don't. So part one, the take-home message. You need photoreceptors to have an ERG. The A wave is producing or the A wave is deriving from the photoreceptors. Importantly, you can differentiate between rods and cones using the normal flash ERG. You've got your B wave, this is deriving from the bipolar cells, and you've got oscillatory potentials on the ascending part of the B wave, and they are most likely coming from your amacrine cells. Cells we do not see in our routine flash ERG. There are ganglion cells we don't see, RPE, horizontal cells, and Müller cells. So Freya, are there any questions?
So right now I don't see any open questions. My apologies. If you would ask a question on the Q&A section rather than the chat function, that will allow us to track which questions have been answered and which questions remain open. But currently, Barbara, we don't have any open questions unless anyone has a burning one they wish to share.
Okay, so either the lecture is really bad or everybody is still on board. So let's hope for the latter. Okay, so the next part will be about ERG protocols. Right, so it's quite important that everybody is doing the same and that we can compare our results. So in 2002, a lot of very clever people sat together and they were producing guidelines for clinical electroretinography in the dog. And then there was actually an update 2012 where they got us a few new rules. And I'm going to show you these protocols just to get an idea what the ideal setting would be and how to do these protocols. Right, so first of all, before we start our recording, we need some settings. So you should do all your preparations at room light. You should avoid strong light exposition to the retina. So what is not ideal is that you do fundus photography, that you do indirect ophthalmoscopy. And if you have done that, then ideally you should wait for 60 minutes. Then the next thing is, if you are stimulating the retina for your ERG, it's really important that enough light hits the retina. So it's always good to induce mydriasis and also to check that that has happened accordingly. And also from the practice, you need to induce your mydriasis before you induce general anesthesia. So make sure before you do the general anesthesia that your patient has got a nice dilated pupil. Then ideally you want to perform general anesthesia. That is of course most important in a scientific measurement, but also in normal practice it's sometimes really hard to do an ERG under awake conditions. You can try, but it's definitely better if you do that under general anesthesia. And if you do so, then make sure that your patient has got proper ventilation, that the temperature is warm enough, and you should always use the same anesthetic protocol. A lot of anesthetic agents, they are altering your ERG signal. So it's really important that you do always the same, because then you can compare your patients. So always do the same, and then you're on the safe side. Next thing is that you should optimize your exposition to the light source. So meaning, depending what equipment you have, that you always put the light source in the same distance to the eye, that your eye is actually positioned axially. You know that with general anesthesia, the eyeball is rotating ventrally, so downwards. And then it's impossible to have a nice, good ERG recording. So bring the eye up, use an eyelid speculum, and to get the eye in the correct position, you can either use a little suture, a stay suture, or you can just use a little mosquito clamp and put that on the eye, but it's important that the eye comes in a central position. And then you should use either a Ganzfeld or mini Ganzfeld dome. That is important for, especially for scientific measurements. There are also ERG machines with an inbuilt light source. For the practical use, that is also okay. And then you need to have some lubrication between your cornea and the so-called active electrode. I will show you in a minute what that actually is. That you can use methylcellulose, or you can just use some sodium chloride solution. So we'll have a look. So this is a little patient under general anesthesia, kept nicely warm with the blanket. Speculum is in the eye, and then we see actually some needle electrodes. So that here would be the reference electrode, and the ground electrode is at the back of the eye. But it's not ideal. The patient could be a little bit better with the dilated pupil. The eye is at the moment in the ideal position, so that's nice, and it's a rather brachycephalic patient, so it's the access to the eye is quite good. This is actually after placing the active electrode. The active electrode is in most cases a contact lens, and then here on top is a light source. That is the system we are using in our clinic, and that is the patient ready to get tested. This is just a reminder to have proper anesthetic equipment, so make sure the patient is properly ventilated, that you monitor them, maybe use a blanket or here's some aluminum foil to make sure the patient keeps warm. And again, it's important that you always use the same anesthetic protocol to get reproducible readings. So the electrodes, so you always have an active electrode, which is most commonly sitting on the cornea. So normally it's a contact lens. And then you have got a reference and a ground electrode. The reference electrode and ground electrodes, they are most commonly in our animals. They are like little needles you can use. They are actually also bipolar contact lens electrodes, meaning that you have got the active electrode and the reference electrode situated in the one contact lens. I'll just give you some examples. So these are some examples for the active electrode. You might know the jet electrode. That is this one here. This has got this little gold ring put in. They give really nice recordings, and they sit nicely on the cornea. They are also quite small, so this type of electrode is especially useful in small patients. So your collie with a small eye, your Sheltie, your miniature Schnauzer, patients like that. The disadvantage might be that this gold ring is quite sensitive to peening. So you can use them a few times, but you need to make sure that the gold ring is always intact. So ideally, you should check with your slit lamp and high magnification that this gold ring is always intact, because it will break after some use. This is the Burien-Allen electrode. This is the bipolar electrode. The active electrode is here, and the reference electrode is built in the same device. Instead of the contact lens electrode, it's always also possible to use a gold foil electrode. This is then situated in the conjunctival sac. This typically gives a little bit lower readings, but is also working quite nicely. Then this is the so-called Koyman electrode. That is the thing we are using at the moment. This has got this integrated light source, which is quite handy, but might not be ideal in scientific readings. And sometimes, in my experience, this active electrode can be a little bit too big for very small patients like your Sheltie, for example. Then this little electrode here on the bottom is something which at least came to my attention quite recently. This is quite nice. There is actually a gold ring sitting underneath, and then this is some sort of silicone material, and you can fit that quite nicely into the palpebral fissure. It's a little bit formed like your gonioscopy lens, so that holds quite nicely between the eyelids, and I think it's quite comfortable for the patient because this material is really nice and soft. And here in the middle is that gold ring, which gives nice recording. So I quite like that electrode as well. And as reference electrodes, we most commonly use needle electrodes. In human medicine, they do their ERGs, of course, awake. And humans don't like to be needled. I'm quite sensitive with that as well, so I run if I see the needle. So they use cutaneous clips. Right, so let's imagine you put your reference electrode into the skin. So that is quite another important point. So the reference electrode should sit at least in your canine patients and feline patients 2 centimeters away from the lateral consus. And the further you put that reference electrode away from the eye, the higher your readings will get. So it's quite important that you always put your reference electrode in the same position and don't vary between patients. So not today 2 centimeters away and tomorrow at the base of the ear. So always be consistent. It's the same with your anesthesia protocol, always do the same. So now we are imagining you have positioned your electrode. So active electrode is in place, reference electrodes at least 2 centimeters away from the eye, and your ground electrode, for example, in the neck. Then you should do an impedance test. So what is that? You should actually test the electric resistance between the electrodes and the body. In simple terms, your electrodes need to flow from the body to your electrode and back. And this is what the impedance is all about. So you test if these electrodes can go quite nicely. And in most machines, you can do that impedance check. And then they tell you how is the impedance of the active electrode and your reference electrodes. And if it's done nicely, everything which is red is bad, because this is about 50 kilo ohms. And it should ideally be below 2 kilo ohms and not higher than 5 kilo ohms. So if you got a bad reading with your ERG machine and you don't know what to do and where is the problem, then it's always a good idea to check your impedance and definitely to do it before you start your recording. That gives you nice information if everything is in place. Typically, if the impedance is so high as in this patient, then your electrode has fallen out or the needle electrode has gone. This occurs quite frequently in long-haired dogs, and then it's difficult to see it. So do your impedance check, and then you are on the good side. Other reasons for a high impedance are, for example, air bubbles underneath your contact lens. So also, you know, if you put that gel onto your active electrode, you might get some air bubbles. So just be careful when you do that. So no air bubbles, nice contact between contact lens and cornea. And again, good contact between needle electrodes and skin. Some people also like to use some alcohol, of course not for the active electrode, but for the needle electrode. So they spray them a little bit after they have inserted them, also to increase the reading, similar to your ECG, so your electrocardiography recordings. So another reason for bad impedance or bad readings is depicted here. I told you that these jet electrodes, they are quite sensitive, and that is a close-up of a broken jet electrode. You can see that this gold ring is disconnected here, so this is not any longer fit for use. Then the next thing you should do before you start recording is the so-called biosignal. What does it mean? The biosignal is just the signal which the electrodes which are flowing without any light stimulation of the retina. And what you don't want to see is that regular signal you are seeing here on the screen. This is most likely a 50 or 60 hertz artifact. This can derive from different electric devices. This can be that you have got an electric cable which is not properly insulated. This can come from monitors. So a lot of electric material can interfere with your reading. And if you are new to ERG and you bought a brand new ERG machine, then it might be a good idea that you try it out in different places in your clinic and find a room where you can do nice ERG recordings. And this can be everywhere. If you're lucky, it's in theater or close to an anesthetic machine, or it's somewhere else, but make sure that you guys get a nice room where you can do your ERG recordings with little noise, with little artifacts. So this is how your biosignal should look like. It can be up and down, but it should be more or less a nice flat line, and everything is in order. Right, this is another little trick. So you did your impedance testing and you did your biosignal, and it's still not really working. Then you can do a little test. So you take a bowl and you take your active electrode and you take your reference and ground electrode and you put them in a bit of saline. And so if you put your equipment in saline, you've got a lot of ions, and these ions, they should float freely between your equipment, and then you shouldn't have problems with your impedance at all. If then the impedance is still high, then it's probably a problem higher up. So maybe this can actually happen, that your machine is not switched on and you actually got the demo readings there, or that the connection between the cables is bad. That is just a little test, practical and simple, you can do if your ERG machine is not working and gives beep. So a bowl, some saline, and then you put your electrodes in there. And then your biosignal should be perfect. Right. Another part of your ERG machine, in most machines it's already set up, but it's good for you to know that every ERG machine will have a filter on board. Just remember that these signals from your retina, they are really small. So these are signals in the area of microvolts. So it's really important that you filter the signal, otherwise you have too much noise and your signal will not be clear. So the typical band filter will sit between, or you should set it between 0.3 and 300 hertz. And of course, a notch filter is something which blocks out that 50, 60 hertz artifact, which comes from your electricity, your wall electricity. But you should not use that, as this can block your signal, so your ERG. So you should not use a notch filter. Right, so after we have prepared our patient, you know how to check for possible pitfalls with your ERG machine. You know now how to use a biosignal and the impedance meter. It's time to start your ERG recordings. And I would like to guide you through two different protocols. The one is the so-called extended protocol. That is a little bit more extensive, and that is useful to differentiate between rod and cone function, and that is more like the scientific thing to also diagnose retinal disease. And then there is a short protocol which is useful before cataract surgery, and also to differentiate retinal from optic nerve disease, for example. So this extended protocol, the idea of that is to differentiate between rods and cones. And there are several steps. So the first step is always to test the rod function. Then you do a test where you combine rod and cone function. And finally, you test your cone function either via light adaptation or with your cone flicker. Why is the extended protocol so important? So have a look at these this table with some inherited diseases, this quite nicely. So you can, for example, diagnose a PRA in a poodle clinically with 3 to 5 years, and with the ERG, it's already possible to do that with 9 months. Of course, for many of these diseases, you will have now a gene test, but still, this difference is quite nice, and so that is one nice reason why to perform an ERG. Right, do you remember all these differences between photoreceptors? Yeah, so rods, they've got a low light intensity, they have got a low flicker fusion frequency, and they are sensitive to blue. Cones, they are rather red sensitive. They need a high light intensity, and they've got a much higher flicker fusion frequency. So how can we do that now? Again, we want to test rod function first, then rod and cone function, and then again cone function alone. Right, we start with the rod function. So how are you going to do that? You prepared your patient in ambient light, and then you darken the room. And then you do a recording of your rods every 4 minutes, and you do that a minimum of 5 times. So all in all, you sit there for 20 minutes in the dark, and you do an ERG reading every 4 minutes. You will use white light for that and a really low light intensity, so 0.01 to 0.02 candelas per square meter. And then if you stimulate the retina, ideally you just should do 1 flush, because if you do several flushes, you will inhibit your dark adaptation. So if you need to repeat your measurements or you want to do some averaging, then do not more than 4 flushes. And the frequency, of course, is really low. Remember the flicker fusion frequency, so these flushes can so really at a low frequency to allow the rods to answer. How should that look like? So that is from the official guidelines, a really nice picture. So what you see is that you cannot really see an A wave. So typically with your dark adaptation, you only see the B wave, and that is constantly increasing and getting higher and higher. And then this is now in our clinical setting. And I put that here to show you the reality. Do I always have the perfect ERG? Well, no, I don't. So these are little artifacts here. This is actually quite a nice recording, but here are some artifacts as well. But you still can see quite clearly that this curve is getting higher and higher and higher. Here are the readings. So this was done in a normal patient, and you can see that the rods are working nicely and they are dark adapting really nicely. Well, then after sitting at least 20 minutes in the dark and recording your rod function, you will do in the next step a mixed rod cone function. So you do now a really bright flash. Remember, the rod function was with 0.02 to 0.03 candela per square meter. Now you use 3 candelas per square meter. That's quite bright. And you should use only a single flash, again, because otherwise the retina is, your dark adaptation is gone. But if you want to do some averaging, then you should wait for 15 seconds before you do the second flash. And this is the signal you typically get after the dark adaptation, the mixed rod cone function. So the rods are stimulated and the cones as well. Then the next step is to do the cone function on its own. And you can do that either via light adaptation or with the so-called flicker function. The idea of the light adaptation is, of course, to bleach the rods. So there is so much light that they bleach and they cannot answer anymore. So how are you going to do that? You do 10 minutes of a constant retinal illumination with now 30 candela per square meter. Just room light is not sufficient. And then afterwards, you do a single flush, again with 3 candela per square meter, presented on a white background. And if you do averaging, this should be with a frequency below 5 Hertz, so that meaning not more than 5 flashes per second. This is how this would look like. And then the next one is that you could then evaluate the cone function with the cone flicker. This is something I quite like because it's really simple and it's quite quick, because after sitting for more than 20 minutes in the dark, then it's quite good to see something happening. So the cone flicker is a nice thing. Remember the idea of that. So remember that the flicker fusion frequency of rods is really low, between below 10 Hertz. And the flicker fusion frequency in dogs is of the cones is 20 to 70 Hertz. So if you use a flicker in dogs with 30 Hertz, then it's impossible for the rods to recover in that time and to give a response. So they will be able to answer the first flash, but then afterwards they're not able to answer anymore. So this is a really nice modality to test the cones only. This is again quite light again, so you do that with 3 candela square meter, again on a white background. This is actually how that looks like. So you will have, so every little wave is one answer from the cones, and you get this really nice and typical waveforms one after each other. Right. So this long protocol, again, is really helpful if you are suspecting a retinal disease and you are not quite sure with your ophthalmoscopy. Then you do your extended protocol, or if you're actually at university and you've got a scientific background, then that is the way to go forward. Much more frequently, we will need a short protocol in our daily clinical use. So for example, before cataract surgery, you might want to know if the retina is working. We had a little poodle the other day and we were performing cataract surgery, and of course we were suspecting PRA, and actually the dog had PRA. That was the reason of the cataract, and you want to know that before the surgery. Then you might have your blind patient with the normal fundus, and you want to differentiate between optic nerve disease or SARS, sudden acquired retinal degeneration syndrome, and then the ERG is really helpful as well. And finally, it might be supportive in patients with so-called central blindness. Of course, if you do your neuro-ophthalmological exam thoroughly, then you might already suspect central blindness, but in some patients it might be useful to do that as well. So examination steps, you prepare your patient again in ambient light. Then you do a combined rod cone function at room light with your standard 2 to 3 candela flash. Then you turn off the light, you repeat the test, the same test with the standard flash within a minute. Then you dark adapt for 5 minutes, and then you test the retina again. Of course, you would expect that after the 5 minutes, your waveforms will become larger and bigger because the retina starts to dark adapt. So that is how your standard flash or your standard ERG would look like. You repeat that. And then after 5 minutes, you do it again, and then you would expect that your waves will become bigger. This is also a good point to remember, that you should not always look at the form of your wave, but also at your value. So there's always the amplitude of your waveforms. This is measured from here to the bottom of the A wave, and then the curve, the B wave, is measured from the bottom of the A wave to the peak of the B wave. And normally the machine will give you these readings automatically. And then there's also the time until the peak of the A wave occurs and the time until the B wave occurs. This is something you should note, and it's always also a good idea to do some ERGs on normal patients and have some reference values for your machine and your setting, so meaning your anesthesia, your setting, your rooms in mind when you do ERG readings. So it's quite important that you do some normal patients as well. Right, Freya, how are we doing? Are there any questions at this point?
Yeah, we do have some questions. I'll just go through them in the order that they were received. So Ravi Rayberg says, excellent flow, Dr. Browse, love your presentation, stay blessed. So that was a very good compliment to your wonderful presentation. And then Dr. Brady Foote had a question about coupling gels. So she asked, are there other thicker gel-like lubricants that can be used aside from methyl cellulose, or do they disrupt the conduction somehow, such as over-the-counter gel lubricants that are cheaper than pure methyl cellulose?
So yeah, that's what I use as well. So I like to use the methyl cellulose as well. And it's also the official recommendation, but it shouldn't be more than 0.5%. And the other option would just to use some sodium chloride. That's also fine, but that's of course a little bit difficult to get the fluid into your active electrode and then put it on the eye to have a good connection. Again, a good idea might be that you check your impedance. So if your coupling agent is rubbish, then you will probably get a bad impedance. So ideally check that beforehand. And if your impedance is like 2 or at least underneath 5, then it's actually working quite good and I wouldn't worry.
Yeah, and I'll second that, having used a number of over-the-counter gel-like lubricants on my own ERGs that we use in the US. We use Gentile, I've used Optics Care. I think that any gel will do that has methyl cellulose in. I think that obviously brands do vary in terms of their ion content, presumably how much sodium chloride they contain. So what I try to do in my own practice is to continue to be consistent with the type and brand that I use every single time.
I completely concur.
So hopefully that answers your question, Brady, but if you have any further questions, obviously feel free to pitch in on the Q&A.
Yeah.
And then there was a question about the general anesthesia. So from Ritika Mandwani, I apologize for pronouncing your name incorrectly, but is general anesthesia really necessary, or sedation would do? And can we also use tropicamide to induce mydriasis in the patients before we start the procedure?
So of course you can do your ERG readings also with sedation. There are also some scientific papers where they use sedation. That's fine. Well, I mean, in my clinical settings, I deal a lot with brachycephalic patients, and I always think that the proper and well done anesthesia with a well monitored patient is almost safer than a sedation. And of course, my advantage is we are in a big clinic here. We've got excellent nurses here. They are all well trained. So having a dog under general anesthesia is not a problem at all. So that's the reason I do it. And again, I try to be consistent with how I do it. But of course, you can do it in sedation. And also, it's possible to do at least a yes-no ERG, so a short protocol, or if you want to differentiate optic neuritis from SARS, you can try and do that in a nice, relaxed patient or an elderly patient. You can try and do it awake. Of course, you can do that. It's not possible to do that for your extended protocol, or it's at least not really recommended. If you want to do scientific measurements, or you are really challenging case where you want to diagnose your PRA, I would never ever do that in an awake patient. Just think of sitting 20 minutes in the dark with the wriggly dogs. This is a complete nightmare. But yes, no ERG, you can always try. I mean, worst case scenario is you suspect a SARS and you get a flat line. You're not sure if it's your readings or if it's the dogs, then well, you can still put it under general anesthesia. So I definitely think that you can, in a clinical setting, you can try it awake or you can sedate the patient. Ideally, you should always be consistent what you do. But of course, this is a normal life and the clinical setting, of course, you can try. How do you do that, Freya?
Yeah, so in our clinic, I'll just add my 2 cents. In our clinic, our yes/no ERGs are actually all done conscious, and actually in a previous university setting, they were also done that way. However, I think it depends on the practice. You know, I think that you can definitely get even quite a wiggly dog to sit still for a few flashes to get a yes/no, and especially if it's a yes, it's an easy one. If it's a no, as Barbara mentioned, I think it's more tricky. One comment that I would have from personal experience, actually more with wildlife species, is the second question that that person asked, which is to use drops to induce mydriasis before we start. 100% give your tropicamide well ahead of any sedative drugs, especially something like an alpha-2 agonist will cause a profound meiosis, and it will be very, very important to precede your induction of sedation or anesthesia with one of those agents by giving tropicamide. I actually often will, in wildlife species where they give very high doses of alpha-2 agonists, I'll actually use a combination of phenylephrine and tropicamide, which some anesthesiologists get concerned about because of the potential epinephrine-like effects on the heart. Personally, I've had no concerns, but certainly something to bear in mind. But yeah, I think that I've actually attempted conscious ERGs in the ECDO protocol and with older patients and had relatively good success. So I think it's not a bad idea to consider, especially in a patient with lots of comorbidities, doing at least an initial study on a conscious patient.
Yeah, especially in the short protocol or yes/no answer, you can try that. But again, as you said, if you've got a flat line, then you might want to repeat it under better conditions. And it really depends on the patient as well. Yeah, I completely agree. Yeah. Have you got any more questions?
Yep. So Caro, I don't know their full name, but asked if we test the electrodes in a bowl, does the kidney dish have to be plastic or can it be stainless steel?
So it shouldn't really matter because it depends on the saline. So you want to have the sodium ions to flow between your electrodes and the active electrode. So it shouldn't really matter. Probably the plastic bowl is better isolated, but it shouldn't make a difference. And I don't do that on every patient every time. This is just some troubleshooting. So if you've got problems with the machine and you don't know where they're coming from, then that might be a nice idea to look for the problem. So where they're coming from. I wouldn't do that in like every case and on an everyday scenario.
So Dr. Zhao Kleiner asks, is the color of the light stimulating the retina make any difference at all?
Well, I believe that there are actually colored light sources available also for the Envision machine we are using at our clinic here. But in a normal clinical setting, I don't think that you use them. So you can differentiate nicely with white light between rods and cones, and in a scientific session, maybe that's a good idea and nice to have. But in a clinical setting and also with scientific settings, I don't think that is necessary. I think you will do fine with just the white light source.
And again, I'll just add, watch out for a new publication in veterinary ophthalmology. The paper was just accepted today. We have performed some studies using the Envision machine, looking at different colors to try and separate out S cones and LM cones. It is feasible, like Barbara mentioned, it's unlikely to be clinically super relevant, but we thought it was something worth doing to look at the different contributions in certain diseases. So there will be a publication coming out. We already have an anesthetized publication in experimental eye research with the protocol. So if you have any more questions, please feel free to reach out.
Sure, cool, well done. Congratulations, Freya.
And then Brady Foot asks again another question. Could you explain the benefit for the short protocol to do the first reading in the light before doing 5 minutes of dark adaptation? And she follows on saying, is it to get a better idea of the contribution of rods to see the change between the B of the two readings?
So the idea of the 5-minute dark adaptation is so that you're doing a combined rod cone answer. So you're doing your 2 to 3 candelas per square meter. And if you do that as a single flush, you will stimulate the rods and the cones. And of course, if you wait for 5 minutes, then the rods will dark adapt and you should get a stronger signal. So that's a very short and brief possibility to see if your ERG signal becomes stronger and if your rods are still on board. That's a simple way to do that. And you don't need to sit 20 minutes in the dark.
And then there are more questions coming in, but I'll just ask one more and then we'll take a clinical case or two. But somebody asks, how much effect does the biosignal have on the ERG? So they follow on saying, even after multiple tries in multiple different rooms, I have never had a good biosignal. Yeah. So we have to perform the ERGs with a bad biosignal.
Yeah, so well, sometimes that happens to me as well. And then it really depends what you're doing. If you're doing your yes/no protocol, a short protocol, again, to differentiate between a retinal problem and an optic nerve problem, then I don't think it's the end of the world if your biosignal is not perfect, because with a good machine and averaging, because averaging helps you to get the noise and the artifacts out of your ERG, then you will still get normally an acceptable ERG. So I wouldn't worry too much about that. But of course, ideally, you should find a room in your clinic where your biosignal is quite good and you don't have any interference. So maybe try and reduce monitors in that room, see if there are any electric cables which are not shielded. And then you can also use, if you have got, you can also, how to explain that, to have some sort of earth line between your recording table to try and get at no artifacts at all, or you can use a Faraday shield, so like a little cage to shield electric noise. But in my experience, the best way to go forward is to really find a room where ERG recordings work fine, and then always do them at that place.
Yeah, and to follow on with that, in my personal experience, when I was an intern at Davies Vet Specialist, they actually did use their own homemade Faraday cage. Yeah. So they actually used a closely knit dog cage, a collapsible dog cage that was made of wire. I didn't see the optimization process to know how commonly much worse it was without the Faraday cage, but certainly I think you can fashion a sort of makeshift Faraday cage on your own without really buying a lot of expensive equipment.
Yeah. Yeah, I think so. We had once an ERG machine, and it was really important to have a good earth line. Maybe you can explain that a little bit better. My English is not good there. And so we were like searching in the entire clinic to find an earth line to reduce the electric noise, and that helped a lot with that machine as well. But the machine I'm using now, it's not such a big problem. And again, I think if you've got some artifacts there and you've got a strong ERG signal in your daily clinic, it shouldn't be a massive problem.
Yeah, I mean, I'll second that if you can find, typically it's piping, so metal piping that goes all the way down to the ground, and you can actually connect, just using a bulldog clip, you can connect something on the machine, either the GAN cells or something. You have to be careful that you don't form ground loops. So I think it's not for the faint-hearted. I wouldn't start there. I would start with a Faraday cage or perhaps even a new machine, because I've certainly found that the newer machines that are purchased now somehow are encased in a much better way and provide a lot less noise.
I completely agree with that. So the machine I was using once was quite old and it was a nightmare. And I gave up at some point and bought a new one. And the new machine works much better. It's much more stable and makes more fun. So I definitely agree with that.
Okay, final question, unless somebody else asks anything, but it should be a quick one. Can you comment on the status of retinal light adaptation and how that affects ERG recordings?
So light adaptation, I think people mean that you must not do any retinal illumination beforehand. So again, well, it's in a normal clinical setting, you would do your normal routine clinical exam, and that is also something I find quite important. So ERG should not be your only tool. So you should always do a thorough ophthalmic exam, and especially do your neuro-ophthalmic exam. And of course, that will include looking at the retina and using your indirect ophthalmoscopy and using your slit lamp. And of course, this will bleach the rods, and then you should wait at least for 60 minutes before you perform your ERG, but you need some time to prepare your machine. You will need some time to induce mydriasis. So keep in mind 60 minutes, and then you should be okay.
Yep, and just to follow on from that, if that person is asking about light adaptation enhancing cone responses, because in humans, there is a 10-minute period of light adaptation that is done after the beginning of the light protocol. Just to explain that it is often, it's written into the ECDO protocol, and it's definitely often performed. What you're doing there is you're permanently suppressing the rod responses to isolate the cone responses. And there's also some evidence in people that cones will increase their response in response to brighter light. I'm not sure that a whole lot has been done in dogs or cats or any veterinary species. So the level of cone adaptation that occurs with bright light. So I think the jury is out. That's a study that probably still needs to be done. So to be honest, I rarely do that 10 minutes of constant retinal illumination. It's so much light, and we know in some animals, especially in rats and mice, you get like also retinal damage from too much light. And I think that for my clinical setting, doing the cone flicker is so much nicer, and it's not so damaging for the retina. So that is what I prefer, at least in my setting. I'm happy with that. So I'm not a big fan of the constant retinal illumination. I think, that's at least what I do. I prefer that. Great. I think we'll let you carry on. Thank you, Barbara.
Okay. Okay, so I brought you two clinical cases just to give you some clinical side of things. So we start with Millie. Millie is a dachshund. She is 9 years old, vaccinated and wormed. She has got no travel history. She has got polyuria and polydipsia, and she is blind for the last 3 days. And that's actually her with her owner. That was at the time I was in Munich. You know, every proper Bavarian has got a dachshund. So I saw a lot of those. And we had to look what's going on. So again, for me, it's always very important not only to do an ERG with every patient, but to do a proper ophthalmic exam and to do a neuro exam. So we had a look at Millie, and she had a sluggish but complete PLR. She didn't have a dazzle reflex, no Menace response, positive lid reflex, and the ocular media were clear. So Millie's fundus looked like that. So actually quite nice. So the optic nerve looks nicely myelinated. There are nice retinal blood vessels. The tapetum is fine. So that looks all good. So where is the blindness coming from? Is it the eye? Is it the retina? Is it the optic nerve? Or is it the brain? So we had a look at the eye. At least the ocular media, they were clear. We could exclude a pure brain problem, because then you would have a normal PLR and a normal dazzle reflex, but no Menace. So that should be not the case. So it's either what leaves us is the retina or the optic nerve. And that is the point where the ERG comes in quite handy. So we can differentiate between a problem of the retina or the optic nerve with that. So we did a short protocol, and we just did our 3 candelas per square meter at room light. And what you see here is actually a really typical flat line. So there is no waveform at all. And then of course you repeat that and you repeat that. And actually I like to do the cone flicker in these cases as well, because I find this response is quite reliable. It was also a flat line, and after 5 minutes, again, a flat line. So what was happening? Millie was suffering from SARS. And SARS, the sudden acquired retinal degeneration syndrome, is a disease which occurs in middle-aged, frequently female neutered dogs. and they get blind quite rapidly, normally within 2 weeks. They can have these systemic signs of polyuria, polydipsia. They might have elevated liver enzymes and cortisol levels. And it's often these miniature breeds like Dachshunds, Schnauzers, Maltese dogs. I actually did a study with those dogs as well, and I was looking for a possible cause of them. And I found some autoantibodies in some dogs. So if that is the cause or the sequel of the disease, I don't know. The reason for that disease is still not unclear, but at least in some dogs, it might be an immune-mediated process. Have you got questions to that?
So far, no questions. It's completely fixed.
Sorry?
No questions.
No questions.
I was just joking that everybody's got SARS. It's all good.
Yeah, it's good. Okay, good. Okay, and then just to remember for yourself, so if you would have a dog with that, also I just go back, also dogs with an optic neuritis, keep in mind that their optic nerve head can look completely normal. And then if you would perform your ERG reading, you would get normal waves, so you would get your normal ERG reading because the retina is working, and then you could locate your problem to the optic nerve. Yeah, just a different case. Okay, next case. So next case is Red. He is an Alaskan Malamute. He is 1.8 years old. He is vaccinated and dewormed. He gets normal dry food. That was at the time I was in the UK. He didn't have any travel history. He was fit and healthy. And the owners were reporting that he is still quite clumsy, and they always thought that it's quite cute, but now they're a little bit concerned that he's still so clumsy and we should have a look. And the eyes, they looked completely normal, and that was all quite cool, and we couldn't explain why there was a problem. And then we did an obstacle a maze test with him. So and I'm going to show you the video now.
Come on, I need your help. Come on, come on. Good, Brooklyn. Okay. Come on. Okay. Yeah.
Right, so who has got an idea what's going on there? What's your diagnosis? Is anybody keen to give an answer? It's always a problem in a webinar that I cannot see if anybody has got an idea. Freya, do we have any contributions?
I'm not sure that the chat function is open, but Nat has bravely put in the chat or the Q&A that day blindness.
Yeah, very good, actually. Yeah. So what you could see in that video that he was quite good at room light or quite dim light conditions, but outside in the bright sunshine, he was really unhappy and couldn't see a thing. So that was also our thinking that he might suffer from day blindness. And that is actually something which occurs in that breed. It's an early onset. The rods are not affected, but the cones, they are. This occurs also in the German short-haired pointer, and in them it's a missense mutation. and the gene deletion in Alaskan Malamutes. So that is what we were suspecting in this guy. So what would you expect when you would perform an ERG? Of course, an extended ERG protocol in this dog. So if we would do the dark adaptation, do you think that would work? Would that dog dark adapt if we checked the rods? Of course, yes. So you would expect that a dog with day blindness, where the rods are working, the dog should have a normal dark adaptation. And then we would do the combined rod cone response. Should that be okay or not okay? Well, yes, at least you should see some sort of curve because the rods, they are working, so there should be actually a wave there. And then last but not least, the cone flicker. What would we expect? Should it work or should it not work? Well, if the cones are not working, we would not see a typical flicker response, maybe the first wavelet, because the rods will contribute to the first wavelet, but then there will not be any answer. So let's see in red what was happening. So we performed dark adaptation, so that was the initial response. So that is a tiny little wave here. And then after 20 minutes, we see a really big and nice curve here. So the dark adaptation seems to work quite beautifully. Then we had a combined rod cone response, and you can see we are also sometimes suffering from interference, but still you can see A wave, B wave. So we have got actually a combined rod cone response. So either the rods or the cones are working. And so finally, we want to see if the cones are working. That is red's ERG here. So you remember how the flicker should look like. I put here a healthy control. You should have these separate little waveforms here, but actually in red you get an initial little curve, and that is the response of the rods, but actually the cones are not working at all. So that was the way to confirm in that dog that he was suffering from achromatopsia. So now we are already at the end of the talk. I hope you are now much more happy to tackle electroretinography. And I hope with these two clinical cases, one a little bit more simple with a yes-no ERG and one with a little bit more extended ERG, helps you to understand how we can use ERG in a clinical setting. And I'm happy to answer any more questions.
So there are a couple of questions, and hopefully there'll be more coming up. One question was, could you please comment on differentiating IMR, which I assume is immune-mediated retinopathy, from PRA in those situations where the retina is not completely degenerate?
Okay, so the question is to differentiate it between immune-mediated retinopathies and progressive retinal atrophy. Is that correct? Yeah. So yes. There is some debate if there next to SARS, so sudden acquired retinal degeneration syndrome, is something called immune-mediated retinopathy. Well, because this has been the topic of my PhD thesis, of course, I believe as long as it's not shown that it's really an immune-mediated disease, I'm quite careful with that term. But most commonly, these SARS cases, they get blind really quickly. So again, in these cases, first step is always to look at the retina and to do a proper ocular exam. And in a SARS case or immune-mediated retinopathy, you would always expect that the retina looks normal. And in some dogs where this disease is going on already for, let's say, 2 or 3 weeks, you might see really subtle little hyperreflectivity, which is normally generalized. However, in a dog with PRA, so the first sign you can see in the retina is that at the border between the tapetum and the non-tapetal fundus, you might get a really subtle line of hyperreflectivity. Of course, then you can proceed to your ERG readings. In a dog with SARS or immune-mediated retinopathy, you typically get your flat line. With a short protocol, with a long protocol, it doesn't matter. And then if it's your typical progressive retinal atrophy case, let's say you've got a dog where the rods go first and then the cones afterwards, so the most common form of it, then you would perform your ERG. You would do your dark adaptation and do your ERG every 4 minutes, and then you would expect that you don't get a dark adaptation because your rods are not working anymore. And then you would do your rod cone combined response, and then you would, of course, in an early case, expect that you would get some sort of response because the cones are still working. So that is what normally would happen. Yeah, and that's a way to go forward and to differentiate between those two.
Yeah, I'll definitely second that. But I think you know, how much you subscribe to the idea of IMR versus SARS being kind of truly causative. I think that suddenness of onset with any of those spectrums of diseases is really the key to appreciating the difference. And then, you know, potentially an IMR could look similar to a mid-stage PRA, but typically those mid-stage PRAs have been going on for a little while, and if you ask the owner those careful questions like Barbara mentioned, I think then you'll end up being able to figure out that it's a PRA. Also remember that PRA is more common in purebred dogs, whereas SARS is actually more common in mixed breed dogs. There are genetic tests available for PRA, so if this was, you know, an important breeding animal, then certainly looking to see what's within the breed in terms of genetic tests that are available would also help to rule in or rule out PRA. I think there are some grey areas with regard to, you know, with regard to these types of diseases. Next question from Eunice Thomas. In the case of mature cataracts, will this affect ERG readings in arriving at diagnosis of normal retinal function or abnormal retinal function?
Well, of course, the mature cataract is blocking the light to a certain degree, but not that you should worry that that is not sufficient to perform ERG readings. So doing pre-cataract surgery ERGs is like a routine thing, and that works really nice. Just make sure that your pupil is nice and dilated. And then that should work nicely. So don't be afraid of that. And we check our cataract patients routinely with ERG before the surgery, and that works always well. And it's actually a reason how to perform or why to perform an ERG.
Yeah, I agree. I think if there's likely to be some minor effect on light diffusion, you know, reflection back of the light that's coming into the eye, but it's not going to change it from being present versus absent. So I think if you're looking for an answer about PRA versus normal retinal function, the cataract itself won't give you sufficient problems. Anonymous attendee asks, I missed the first few minutes. Did you talk about the C wave, or is it not being covered today?
I was not talking about the C wave because with your typical filter settings in your ERG machine, you will not see the C wave. So I did not cover that because it's not what you see in your routine ERG.
Okay, Roberta Covey says, in my experience, in some dogs, I have a deep negative deflection of the signal soon after the wave. I wonder if this is the A wave. Perhaps you can comment and just explain that. And this happens in all the registrations of the same dog. Can you give me an explanation to this phenomenon and suggest how to avoid it?
So I'm not sure if I understood that correctly. So this lady sees a negative wave after the A wave? I'm not 100% sure. What is possible is that... Sorry?
It's not clear whether
after the A wave or the B wave.
About the A wave or the B wave.
Yeah. So, well, it's possible that you see some part of the oscillatory potentials between your A and B waves. So that would be the reason for that, and that would derive from the amacrine cells. So nothing to be worried about. And to be honest, if it's happening after the B wave, I wouldn't be too worried about that at all, because with our normal ERG, all you need really is the A and the B wave. So maybe in this case, it might be a nice idea if you would like to send me an email with the recording or a picture of that recording, and I'm happy to try and help with that. So maybe that makes most sense, because we are both not sure where that special wavelet is. So I'm very happy for that lady to send me an email, and I try to help with that.
Yeah, that sounds like a sensible plan. The only other thing I could think of is perhaps sometimes when you have a lot of interference from the light that's the stimulus, you can end up with quite a large kind of almost vertical looking signal right at the time of light onset. My experience is that that's an incorrectly grounded light source. So that might be a question for the manufacturer, or perhaps for an upgrade of the light source. But yeah, I think the best thing for that would be to share a recording so that we
screenshot.
So they actually did answer real quick. They said after the B wave, so definitely not light source derived. It probably, to me, it's probably the dog blinking, because the delay, it has to be processed by the brain. So the delay of the blink onset from the dazzle is longer, implicit time, longer peak time than your delay for the ERG response. So if you're not already using a speculum, I would recommend you use a speculum, or just like Barbara said, I think it's probably not anything to be particularly worried about if it's after the peak of the B wave.
Yeah. But again, she can send me a screenshot.
So Shriram Ganesan asks, what is the importance of a B to A wave ratio in the clinical setting, for example, in dogs with mature cataracts or severe vitreous degeneration?
Well, you can always use a B to A ratio to evaluate your ERG readings. For me personally, I've got values I expect from my patients to have from a healthy patient, and I keep those in mind. For me, that's more important. You're asking about cataracts and vitreal degeneration. In my experience, they do not reduce the ERG so much. And again, for vitreous degeneration, especially before cataract surgery, that is something you would normally diagnose with ocular ultrasonography, which is for me even a little bit more important than the ERG before cataract surgery. So it's good to know if you've got vitreal degeneration, if the retina is in situ. That is something you don't see with the ERG, but with your ultrasonography. So before you do cataract surgery, that is another really, really important, or maybe the most important thing to do before cataract surgery.
Yeah, I definitely agree. I think the B over A wave ratio is not clinically particularly applicable. In human medicine, the B over A wave ratio is used to determine the potential for congenital stationary night blindness, where you actually have a defect in the transmission between the photoreceptors and the inner retina. And so in that situation, your A wave will be very profound because the photoreceptors are firing, but your B wave will be very small. And so the B over A wave ratio will become very, very abnormal compared with a normal person. So in my experience, in clinical practice, I have never felt the urge to assess or look at the B over A wave ratio. But certainly in my research, it's an interesting piece. So Dr. Alex Stigmund says, with regard to diabetes mellitus, do adjustments need to be made in the interpretation of the readings? Like if you get a reading of 60, I presume that's 60 microvolts, do you say that that could be normal since the dog is diabetic?
Well, again, so I wouldn't go for values. So you need to have your own values in mind if you do your ERG recordings. And there are some machines you will get higher readings and others lower. And again, depending if the dog is anesthetized or not. Well, in a diabetic patient, I wouldn't worry really. I mean, what do you expect in a diabetic patient? He will probably have got diabetic cataracts. He will need to have cataract surgery. So there is not really a need for an extended protocol. All you want to see is that it has got a positive retinal function. And then in most diabetic patients, you can also use your common sense in addition. So normally the dog would become blind from one day to the other, and the owners would report that the dog could perfectly see before the onset of the cataracts. So I wouldn't worry even if the amplitude might be a little bit lower. It's not the end of the world. For a clinical setting, it doesn't matter in my experience. So don't be worried.
Yeah, I mean, I would definitely concur with that. I think that you need to establish what a normal is for your practice. Yeah. You know, I think that cataracts in themselves will have a small but relatively insignificant input on the ERG retinal function. So if you're finding that your normals are running in the 200 range and you get a pre-cataract surgery case that has a 60, I would probably be very cautious. You know, I think that there are a couple of options, and we often talk through owners is, you know, if you think that there may be some, you know, perhaps inflammatory component or something that you could treat, perhaps you could consider, you know, waiting a few weeks, treating in whatever way you feel would be most appropriate, perhaps some anti-inflammatories if that's the way you thought was the way to go. And then retesting the ERG. But I think if you are having an abnormal result, I think it's very hard to blame either the cataract or the diabetes as the only cause of problems.
Yeah, and again, I would always perform an ultrasound of the eye, especially if you consider cataract surgery in your diabetic dog. You often get a lens capsule rupture, especially in the equatorial region. So ERG is fine, but if there's anything wrong, always do your ultrasound, but especially then I would double check if there's anything wrong. You still can get an ERG with a detached retina, so keep that in mind as well. Definitely do your ultrasound, make sure that everything is fine.
And if you really want to do your due diligence and you're concerned enough, you know, you can certainly consider either reviewing previous ERGs on similar patients or even performing ERG on a normal patient if you have your own dog or something. I'm not advocating for that necessarily, but if you're concerned that your machine is not functioning correctly, then that would be the best place to start rather than cancelling the cataract surgery for a case that perhaps was okay to have surgery.
Yeah, I agree.
So that's all the questions that we have in the Q&A, unless anybody else has any follow-up questions or anything else that they would like to comment on. We'll maybe give a couple of minutes.
Yeah. I'm also very happy if people send me an email. If there are any later questions, it's not a problem at all.
Yeah, we got one comment from Teresa and Zavadliova, which says very nice and practical presentation. Thank you.
Thank you very much. It's my pleasure. Thank you.
Yeah, we'll leave the chat open or the Q&A open for just a couple more minutes as people,
Sure.
It looks like people are just starting to drop out a little bit.
That's fine.
Before everybody leaves, I obviously just want to say a big thank you to Dr. Browse. For obviously doing a wonderful job with our presentation. If you do have any further questions for either of us, we're more than happy to answer questions. You could probably send them to the OnVision group and they can send them on, or I did put my email in the chat section as well. You know, yeah, I just wanted to really just spend just a second just honouring the life of one of our dear colleagues, Dr. Gilben Shlomo, who sadly passed away recently. You know, I know that he's been in our thoughts a lot recently, so I just wanted to comment that his loss was a tragedy for veterinary ophthalmology. He's contributed so much.
Yeah.
And then to all my colleagues in the United States, today is election day, and so I would encourage you, if you do one thing today, make sure that you have a plan to vote and you have voted. And if you've already voted, please encourage other people to vote. Our lives definitely are on the line here. So, little plug.
Thank you, Freya. That was well spoken. Yeah, I would like to say thank you as well to you, Freya, for for that nice discussion, for leading the talk. I would also like to say thank you to OnVision for that honor to speak tonight. And they were so kind and helpful, sending equipment over to me and making an electric test and see if everything would work beautifully. So they did a wonderful job. Yeah, so once again, thank you to everybody.
And thanks to Vision for hosting these free webinars. I'm sure there'll be more to come.
Great.
Very
really
grateful
great.
for
yeah, these are really difficult times, and we miss our colleagues. We normally see each other at our yearly conferences, meeting friends and being together. It's such an important part of our ophthalmology life, and missing all that is really bad. And having at least these webinars where we can hear each other, and yeah, this is really important. So thank you very much for that.
Yeah. So there was one final question, just to recap. When troubleshooting, so they ask if this is correct. So number one, check the electrode placement. Number two, check the gold rings. I would probably check the gold rings before the electrode placement, but yes. And then three, check impedance. Any steps that I'm missing?
No, I would probably start beforehand. So yeah, well, either work your way from the patient to the machine or the other way around. So if you start with the patient, yes, definitely make sure that all the needle electrodes are sitting underneath the skin and nicely. Maybe apply some alcohol as well. Make sure your active electrode, which is normally your contact lens electrodes, is sitting nicely on the cornea without any air bubbles. Then make sure that all the cables are connected to the machine. Make sure your machine is switched on. Make sure your machine is connected to the computer, and yeah, that everybody has got electricity and is switched on. I had that the other day where actually somebody removed the line between the computer and the ERG machine and nothing was working. And then you need to go step by step to see where the problem is. And if you have checked everything, then of course check your impedance. That helps you to see if the contact between the electrodes and your patients is okay. And then again, check the biosignal if that is nicely, and then I think you're safe and ready to go.
Yeah, absolutely. I think having an SOP for these types of things is actually really helpful. When you have perhaps technical staff or nurses doing the process of preparation, even a simple thing like making sure that there's adequate dark adaptation, that drops are applied at the right time. You know, I think having an SOP somebody can just pull up and essentially follow step by step is really, really helpful. And using the ETVO guide as your master there, that can really help you.
Yeah, I concur.
And then one more question. What about examples of where the A wave is lower than the B wave in terms of amplitude?
The A wave is lower in amplitude. I'm not sure if I understand the question correctly. So the A wave will always be negative and the B wave will always be positive, at least in your combined rod cone function. So that should normally be the case. But I'm not sure if that is the question or if I misunderstood that.
I wonder if the interpretation is what are you expecting to see the A wave be bigger than the B wave in terms of the amplitude, maybe not the direction, but the amplitude?
No, well, at least in your combined rod cone function, the A wave is normally much smaller than the B wave.
Yeah, I've not come across any dog or cat or any species where the A wave is actually bigger than the B wave, because the B wave is a summed response from multiple cell types, whereas the A wave is purely derived from one cell type, which is the photoreceptors. So yeah, expect to see your A wave smaller.
Oh, Freya, you've gone off.
Feel free to follow up, Daga, if you had further questions, perhaps sending us an email if you need further clarification.
Yeah, that's fine.
Oh, sorry. So they followed up by saying, sorry, the A wave is bigger than the B wave. So if you have a large A wave and a small B wave. Okay, that clarifies things.
Yeah. Oh, this is weird. Maybe she can send me an email with a screenshot as well, and I'm happy to discuss it with her. That sounds weird.
Yeah, I mean, it sounds like it could be a congenital stationary night blindness. It's very uncommon.
Yeah, but if she sees that all the time, then something is wrong there. So maybe again, it's a pleasure for me. Send me an email with a screenshot. We can discuss a case. It's fine. But yeah, maybe that's the best way.
Okay, well, we're having lots of messages of thanks. We thank you all for coming.
That's really
yeah,
nice.
we'll happily answer further questions on email if anyone has any. We don't have all the answers, but we'll do our best.
We do our best, yeah. Okay. Good. Yeah, so with the email, it's not a problem. You can send them to Envision, and then I'm sure these guys are happy to forward them to me. So yeah, we just do it that way. Okay.
Sounds good.
I think we are good. Yeah, so we're a little bit early. I'm sorry for that. But yeah, better early than too late. So once again, thank you. And then we say goodbye at this point. Right.
Sounds good.
Okay, everybody, thank you so much. And then bye-bye.